Chapter 8: Reclaiming Our Health, a Counteroffensive Blueprint. History shows that takeovers can be reversed. This is not a moment for despair, but for a strategic counteroffensive. The single-payer solution is not a radical fantasy. It is the logical, moral, and economical endgame, the only system fundamentally aligned with the principle that healthcare is a human right. Our blueprint for this counteroffensive is a practical, three-phase plan that leverages a specific, drafted piece of legislation as its Phase 1 prototype, the Washington Health Trust. It is a state-level bill engineered to dismantle the denial machine, an administrative waste we have documented throughout this book. The Washington Health Trust, while a product of its moment, stands on the shoulders of decades of state-level activism and legislative courage. Its core principles of a unified public payer were forged in the hard-fought campaigns of states that dared to challenge the insurance complex long before it was politically conceivable. Vermont's 2011 push for a single-payer system, though ultimately blocked, provided a crucial national template and proved the political will existed. California's perennial legislative battles, with bills like AB 1400, have continually refined the economic arguments and mobilized a vast coalition, demonstrating the scale of the fight. In Washington itself, the earlier passage of the nation's first public option, Cascade Care, in 2019 was a critical proving ground, revealing both the promise of public models and the limits of competing within the existing for-profit framework. The trust is the direct successor to these efforts, synthesizing their lessons into a more advanced and politically viable design. This lineage is not incidental. It is proof that the counteroffensive is a sustained movement, learning, adapting, and advancing with each campaign. A. Unified public funding, replacing the profit motive. The first and most critical feature of the trust is its financing. This is the linchpin. The problem: the current multi-payer system is not merely complicated, it is a weaponized financial architecture. The denial machine thrives on fragmentation. Each funding stream, state employee plans, Medicaid, Apple Health, ACA subsidies, is a silo with its own rules, creating administrative fog that for-profit insurers use as cover to deny claims and generate profit. This systemically incentivizes churn, the practice of pushing out sicker, costlier patients while recruiting healthy ones, and turns the act of receiving care into a constant financial and bureaucratic battle for patients and providers alike. The trust's solution: the trust doesn't reform this system, it replaces it. By consolidating these streams into a single, publicly accountable pool, it severs the direct link between an insurer's shareholder returns and a patient's denied MRI or prescription. The financial incentive flips. The system's goal shifts from minimizing medical loss to maximizing the health of the entire population. The trust operates on a not-for-profit basis, where every dollar saved through efficiency or prevention is reinvested into expanding care or reducing cost burdens, not distributed to investors. The funding mechanism: it is financed by a dedicated capital gains tax and fair share payroll contributions. This is not a new tax on the middle class. It is a replacement tax that substitutes for all premiums, deductibles, and co-pays. For the vast majority of families and businesses, economic analysis shows this results in net savings. This unified risk pool, where the healthy and sick are covered under the same social contract, is the precise antidote to the hostile takeover, a democratic financial reclamation of our health system that aligns funding with health outcomes, not corporate quarterly reports. B. Simplified coverage, starving the administrative beast. The denial machine's army is not just AI and algorithms. It is a legion of billing specialists, coders, and prior authorization clerks. The problem: previous chapters have detailed the insanity. A single hospital may have to navigate contracts with dozens of insurers, each with different forms, codes, and rules designed to obfuscate and deny. A primary care physician's office can employ more staff for billing and insurance negotiations than for actual patient care. This administrative bloat, consuming an estimated 31% of U.S. healthcare spending, is not an unfortunate byproduct. It is a core profit center and a deliberate barrier to care that wastes clinician time and fuels burnout. The Trust's solution: one card, one claim system, is a direct and fatal attack on this complexity. With a single standardized set of benefits, eligibility rules, and provider payment rates, a clinic can fire its team of billing specialists and hire another nurse or social worker. A doctor spends time on a patient's chart, not on the phone with an insurance clerk arguing over medical necessity. The projected hundreds of millions in savings under the trust come directly from defunding and dismantling this parasitic bureaucracy, redirecting that river of money back to patient care. This simplification is not just an administrative tweak. It is a profound cultural shift that restores the relationship between patient and provider, removing the for-profit middleman from the exam room. C. Wraparound Medicare and D. Veteran-friendly integration, a compassionate and strategic design. The most politically potent attacks against single-payer involve fear-mongering about taking away existing coverage. The trust is engineered to turn this weakness into a strength by honoring and improving our best public systems, demonstrating that reform means enhancement, not eradication. For seniors, wraparound Medicare. The trust does not replace Medicare. It fulfills its broken promise. By using its public financing to cover all deductibles, co-pays, and gaps in coverage, like dental, hearing, and vision, it effectively eliminates the need for costly, confusing Medigap or Medicare Advantage plans. It turns Medicare from a partial benefit that leaves seniors vulnerable to bankruptcy into the truly comprehensive program it was intended to be, protecting a beloved institution while making it better. This strategic wraparound approach neutralizes a powerful line of opposition by guaranteeing that no senior loses benefits and everyone gains financial security, transforming a key demographic from a perceived opponent of change into its staunchest ally. For veterans, veteran-friendly integration. The trust holds the VA system sacred. It recognizes the VA, as detailed in Chapter 7, as our national prototype for integrated nonprofit care. The trust acts as a seamless partner, covering everything the VA does not: emergency care out of network, dental, vision, and services for family members, without forcing veterans to navigate a separate hostile private insurance market or choose between systems. It proves that a universal system can respect and reinforce our public commitments, not erase them. This model ends the VA or nothing dilemma and provides veterans with a continuous, dignified coverage guarantee, honoring their service by fixing a fragmented system that has too often failed them. The trust as the three-phase blueprint. 1. Phase 1. The legislative beachhead, years 0 to 2. The Washington Health Trust is Phase 1. It is the concrete, actionable bill that can be introduced, debated, and passed in a pioneering state. Its success provides the model for replication in California, New York, Illinois, and Massachusetts. This state-level action bypasses federal gridlock, creates tangible proof of concept, and builds the political power necessary for national change. 2. Phase 2. The public choice, years 2 to 4. The trust's design provides the exact architecture for other states to launch powerful public option plans that are not weak competitors, but premium, integrated systems based on its unified financing and simplified administration. These state-based options would demonstrate the superiority of the public model within the existing marketplace, winning over public sentiment through superior performance and lower costs, and creating a competitive race to the top among states. Third phase. 3. The federal synthesis, years 4 to 6. The trust's respectful integration with Medicare and the VA provides the template for federal legislation. A national Medicare for all system would not be a disruptive overthrow, but a synthesis of these proven, popular public models into one seamless framework. The Federal Act would set national standards and provide baseline funding, while allowing states the flexibility to administer care, much as the Washington Trust model outlines, creating a resilient, federally backed, locally administered, universal system. Conclusion. The counteroffensive begins with a bill. The Washington Health Trust is more than policy. It is the fully weaponized counteroffensive. It surgically targets the denial machine's financial engine, starves its administrative army, and outmaneuvers its political fear campaign. It answers the question, how, with the most powerful tool in a democracy: a specific, ready-to-pass bill. The path is clear. The blueprint is drafted. The counteroffensive begins not with a protest, but with a vote for a system where funding follows need, bureaucracy bows to care, and our public promises are finally kept. Let's win it. There it is. The blueprint is drawn, and the case is clear. A single-payer system isn't a radical leap into the dark. It's a step onto a path we've already built and proven. The VA shows us that when you remove the profit motive, you get better care for less money. The financial models prove we can afford it, and the three-phase plan shows us how we can get there. This isn't about wishing for a different system. It's about strategically expanding the one that already works, leveraging the VA, strengthening Medicare, and building a system where health is a right, not a privilege. Which means the final question isn't about policy. It's about power. Who will build the political will to make this happen? How do we overcome an industry that spends billions to protect its profits? The answer lies not in Washington's corridors, but in our communities, our clinics, and our collective voice. This leads us to the final word, the conclusion of hostile takeover. If we have the evidence and we have the plan, what will it take to win?